All right, Dr. Hurley, I think we are ready for you, sir.
We got the this deal activated. I've got a pointer on it. Looking for.
Try now.
Okay.
Up and down.
Perfect. Up. Down. Audio coming through okay?
Looks like.
Okay, great. Okay, guys, thanks for coming tonight. Thanks for your patience in allowing us to get this. And allowing us to get this thing set up. As I explained to you before this started, we're going to hopefully start recording our educational meetings and our monthly meetings, not here just in Monte Vista Ambulance, but in as many of the ambulance services as the medical directors are interested in participating. The idea is to make them available to all of you within all the EMS services in the Valley for study and perhaps enlightenment. We hope some enlightenment or clarification of certain things that we as medical directors think are important here at the local level. So tonight is an inaugural night for trying to record this. We will, if the quality is sufficient, post this probably on the RETAC website under the Education tab. So maybe within a week or so, look at that and maybe you can find it there. But getting back to just what we always do, we'll just do a very brief PowerPoint here on some items that I thought would be of interest and be of importance to us. We're going to talk about 4 separate items is all. And first one, we're going to talk a little bit about non-invasive blood pressure readings. Those, the technical word for the readings that we get when we put on our monitor cuff. We're going to talk a little bit about what those are, how they're different from a manual reading, how in some cases they're not as good as a manual reading, and ultimately the take-home point is remember to do a manual reading in certain scenarios. We'll talk about that and why. Second topic that we'll talk about are some resuscitation reminders, and I apologize for you guys sitting on the sides if you want to move in. But I'm going to put forth 2 resuscitation reminders if you want to have improved outcome in your cardiac resuscitations, the uncomplicated cardiac resuscitations. To improve these outcomes, reach for your iGel rather than your ET tube in general for first pass attempts. And secondly, do as much of your resuscitation on scene as you can. If you stay on scene for a period of time, and it's going to be a different period of time in different scenarios, which we'll cover, you can improve outcomes. We've got some data to show you that supports that statement. The third thing we're going to remind, and we've talked about, lights and sirens. I'm going to give you some figures about lights and sirens mortality, just as a reminder. And lastly, we're going to talk about the MOST form that's used in Colorado. It's green, just like the typing on that deal. And we're going to kind of go through that and show you guys how that can actually be of some practical help above and beyond just, is he a no code, yes or no? So that's today's items. We'll start with non-invasive blood pressure. So NIBP is the abbreviation for non-invasive blood pressure. What it refers to is when we use our monitor to record a blood pressure rather than a manual. These monitors do a very good job at it. All the monitors by all the companies have to meet standards, and they're very, very good. But they're not infallible. And there's a few scenarios where they need to be double-checked. And the main scenarios are extremes of scale. If you get really low blood pressures, or to a lesser extent, really high blood pressures, the non-invasive blood pressure reading that you get from your physio-control life pack is not going to be as accurate as we would like. It falls off a little bit. And the reason for that is that these monitors, which are fantastic, is not actually, even though when we look on a monitor screen, we look at systolic and diastolic. It's not measuring the systolic and not measuring the diastolic. It's actually measuring a function of the mean arterial pressure. It's measuring the pulse pressure, which correlates with the MAP, or the mean arterial pressure. And then it uses a complicated set of algorithms to calculate what the SBP and the DBP would be in that person that has this certain pulse pressure. You can see if you get to very low pulse pressures at the lower end of the scale, the margin of error can increase because you're trying to measure something that's smaller. So what that leads to is that hypotensive states, where a person, say, has a reading of 90/60 and they look hypotensive and it fits their clinical picture, that may be overestimated, meaning that they're possibly more hypotensive than the machine reads, which of course is bad news for them and also bad news for us, because it means that they're sicker than we think that they are. We're going to talk a little bit about what to do. So at any rate, without going into great detail, that's the reason that the SBP and the DBP readings are a little bit off at super low levels. Now, the map is also displayed on the monitors. And as we just said, these monitors are actually measuring pulse pressure, which correlates very well with map. But if you guys are like me, it's very, very rare that we really look at or care about the map reading on the monitor. And Drew's going to come up in a minute and just to put it up here so to remind us all where it is. But it shows up on every blood pressure reading, but we're so used to looking at systolic and diastolic, because that's what we run on, that we don't really pay a lot of attention to map. But I'm going to talk to you about one situation where we can, two situations where we can and should pay attention to map. One is if it's a suspected sepsis patient. The map is important, the mean arterial pressure is important in your sepsis patient, because it's been well established in many, many clinical studies that a map of 65 or less correlates with end organ damage. And so it's almost a hard action point for ER docs and pre-hospital providers that are trying to maintain blood pressures above a level X. The map in sepsis is 65 that you're trying to stay above, and basically the rules is that you give your crystalloid at the 20 per kilo ratio until you get the 2 liters in. And if that isn't working, if the map still isn't at 65 or over, if you're a paramedic and have authority from your medical director to use pressors, that's when you start pressors, whether it be dopamine or levofed or epi. So a map of 65 is something that to kind of file away as an important reading in sepsis. But the other place where maps are important is when you're trying to trend somebody who you are worried about becoming more and more hypotensive. And this may be not just the septic patient, but say the trauma patient with multi-system trauma. Maybe you're worried about intra-abdominal bleeding. You've titrated their blood pressure to 90 systolic or something, because that's what we've been taught to do, is to not over-resuscitate and so forth in trauma. But you're trying to see, is that pressure really going down? Rather than just looking at the systolic and the diastolic, look at the map and then see what that map is 5 minutes later and 5 minutes later, and that's going to give you a better idea of what this patient's real status really is. So a little bit of extra help on the map. So manual blood pressures, as we said, are more helpful, and one of the reasons that they are is when you do a manual blood pressure, which we won't review here, you guys all know to do that, you're hearing when the systolic comes in and when the diastolic comes in. So you're actually getting the systolic and the diastolic as actual measurements, not as a function of another measurement. And for that reason, they're considered more of a gold standard. Now, the true gold standard blood pressure is not a manual blood pressure cuff. It's an invasive blood pressure cuff where, you float an art line and find out what the pressure really is. Manual readings, on the flip side, though, do have limitations. As you guys all know who have to do them in pre-hospital environment, a lot harder than it is in the ER because of noise and chaos and other things. So there are some limitations. I'm not saying that it is a gold standard that's perfect. Another thing to be aware of is that many trauma facilities and critical care units require a upon admission, the recording of at least one manual blood pressure when you're entered into the level 1 trauma bay. And it's just for that reason. They're going to go ahead and use their NIBP, and later maybe their invasive blood pressure if they're sick enough for trending and such. But early on, they want to know and correlate what the manual is with the thing. And so for all of those reasons, it's a good idea to know that, and a good idea to think about checking a manual reading, not on every patient, but on your sick patients, and especially the ones that might look a little sicker than what the blood pressure reading indicates. So maybe you go out on a nondescript page, adult male, been feeling sick for several days, you get there, and that's all that you really know until you take further history. One of your guys is getting a set of vitals while the other one's kind of starting to talk to the family and figuring things out. And you find out that the blood pressures, you know, in this adult male is 130 over 80, and you're going, oh, that looks pretty good, you know. I need it maybe a little low, but it's not awful. But you're looking at your patient and going, he looks like he's in shock, and he looks like his pressure should be 90 over 60. At that point, after hearing what we just talked about tonight, your idea is not to push the record NIBP button again on the monitor. It's to say, go into the rig and give me my manual blood pressure cuff and stethoscope, and I want to check this. And then you find out that his pressure really is 90 over 60. It's like, oh, that fits, and then you act accordingly. A little pearl on the limitations of NIBP. Drew, show us what that would be on the on our monitor over there. Just mainly the map. I wanted everybody, some of our BLS providers might not have looked at this, but
Have a volunteer, please.
all right. Good.
And Drew, wasn't it that Nikki had said that don't let those cords bounce on the floor of your ambulance because it'll give you a false reading?
Yeah. The coil cords will give you a false reading because you're supposed to sit there and be patient and calm, and you got this thing moving all around. It's picking this stuff up. So it's always good to, if you don't have to use this cord.
Yeah. The technology to measure those pulse pressures through that little cord is just fantastic, you know. And so, yes, there are a lot of things that can go wrong. You want the cuff to be at heart level where you can. The cuff needs to be appropriately sized, of course. Avoid interference with a lot of vibration on the cord,
Right.
that type of a thing.
So we got 137 over 81, and in the lower left-hand corner, there's a little 97.
Map 97.
That's your map.
There we go. So that's a super small number. Those of you that aren't used to it, come and see where that is. So you know where the 137 over 81 is under the NIBP bar, but at the very bottom left, and it's small enough to kind of miss our attention. And pretty soon, since we're so used to looking at what we look at, we don't even see it. But what I want you to do is to start seeing it, thinking about it. In low blood pressure cases especially, really think about it. In sepsis patients always think about it. And in patients where you want to trend their blood pressure to see because you're worried about losing it, then be aware of that and keep that in mind. So that's it on NIBP. Thanks, Drew. See what happens.
Okay.
There we go. Okay, second item. Improving survival in out-of-hospital cardiac arrest.
Blood pressures.
Ah,
If we're going to be doing this, we absolutely have to have high-quality manual cuffs in our rigs.
okay.
I can't tell you how many times I've gotten out the manual rig, you pump it up and it pops off there, or the balloon pops out. We just need to get some high-quality ones.
Copy.
25 of them, and as we wear them out,
Throw 'em
replace
away.
them with good ones.
Let's replace it.
It's embarrassing. It's a problem. Everybody have it? I mean, you guys agree? Yeah. I carry my own around.
What's that? Okay.
So
There's a way you can calculate them, but still not seeing.
Well, that's a good point, and we will work on that. Dr. McDougall, do you have any comments on NIVP readings and manual readings that I didn't touch on?
No, I don't have anything to add.
Okay, okay. Thanks for the pointer on that, we'll try to do that. Okay, cardiac arrest. 2 strategies that have evidence that show that they will improve survival rates. First strategy is, when possible, work your patient at the scene, at least for a while. We're going to talk about in a minute when we look at the studies what for a while is, and you'll see, like so many things that you guys do, it depends. It depends on the situation. But rather than defaulting to, adult out of hospital cardiac arrest, quick shock, look, get them in the rig, do compressions while we're getting them in the rig, and then do most of our interventions on the road, we're going to think a little bit differently. The ROC trial, the Resuscitation Outcomes Consortium trial, which was a trial of observational studies. They used 5 years of data for between 2015 and 2011, 192 EMS agencies. They had thousands of cases that they reviewed. And in those patients, and they just did out-of-hospital cardiac arrests that weren't complicated by trauma, pediatrics, hypothermia, immersion, drowning, those types of things. They found a 4% survival in those patients who were transported before ROSC. Survival to discharge increased to 12% in those patients whose transport was delayed until after achieving ROSC on scene. So fairly simple. A lot of confounders that make this not absolute, as all studies in medicine. There are so many things that can kind of play into it, but I do believe that most EMS medical directors and ER docs and academicians feel that while the numbers could be tweaked one way or the other, outcomes are better if we do high quality CPR, do early administration of electricity if there's a shockable rhythm, try to get ROSC before we load and go. So that's one strategy. It's just a reminder. It's nothing new to you guys, but I wanted to give you some numbers to do that. And again, the reason is, since high quality CPR and early treatment are key determinants of outcomes, you don't want to compromise those. There are also good studies that show that CPR efficiency goes way, way down if you're trying to do it on a moving patient. It can be done in the back of an ambulance effectively, and there's data that seems to support that, but there is no data that supports the efficacy of transferring from the scene to the gurney to the back of the ambulance where you can really get secure again. So think about that when you do stuff. Second strategy. See, we're losing that one down. Second strategy has to do with airway management. And basically, the answer on the second strategy is, if you're doing airway management, reach first for a supraglottic airway and out-of-hospital cardiac arrest. We're not talking about all comers, just adults with OHCA. Supraglottics have shown to be associated with better outcomes in routine cardiac arrest than the use of an ET tube. The study that's based on is called the PART trial. It stands for the Pragmatic Airway Resuscitation Trial. It's not too old, about 2018. This was a randomized controlled trial that showed increase in survival of 15 to 18% when an SGA was used as the first airway of choice rather than an AT tube. They took all of these patients, and I think it was 3,000. Because it was an RCT and not an observational retrospective study, it was prospective, where it's kind of like, okay, Drew, today you're going to use SGA for all cardiac arrests. Tomorrow you're going to use AT tubes for all cardiac arrests. Same thing for all of you here. And they went and they tried to match all of these populations, and it seemed that the SGA cohort did a little bit better. And when you see that 15 to 18%, I just remind you that that's kind of what we think about when we think of what's the likelihood of us saving somebody that is in cardiac arrest at the scene. If we do everything correctly, the best we can do is 15 to 18%, but we want to do the best. And that's why I'm saying, second take-home point today, your next cardiac arrest, reach for your supraglottic first, unless there's some other confounders going on.
I think that may have a good battery. I got you here.
Okay. Here's some of the results that are kind of interesting if you look at this. That they used for their supraglottic, the King LT. We use the iGel, of course, and the iGel, I think, is even more effective in most individuals' opinions than the King LT. But this was done with the King LT versus the ET group. You could see 1,500 more or less. 27% had ROSC at ED arrival. 24% had ROSC at ED arrival. But the key, survival to hospital discharge or survival to hospital discharge with a good Rankin score, that is functional. 7% in the King group, 5% in the ET group.
I have a question.
Yeah.
Does this trial take into account certain techniques such as apneic oxygenation and whatnot, or did it mention that?
It did not, no. And it does not take into consideration video laryngoscopy versus manual laryngoscopy. It was just whatever the paramedic was most comfortable using for their ET tube or their airway management is what they got to use. And it did not include other confounders. Basically, there have been lots and lots of studies to see what the best approach is, because we've known for a long, long time that that first pass success is difficult at times with an ET tube in the environment, in the pre-hospital environment, and that the misplaced airway during transport leads to trouble. So,
Great. It looks like there's two reasons for that. One is, it looks like the iGel is quicker, by about 2.5 minutes.
yeah.
And it looks like the success rate is better with the iGel. Just like there it says unsuccessful first attempt, only 7% with iGels, 44% with ET tubes.
Yeah,
That's part of the reason right there.
exactly. That's part of the reason. And they go through and parse this very carefully. It was a really well-run trial, and they did a lot of talking about why that was as high as it is, because that's actually higher than what many institutions' experience is, as far as that is the inability to get the tube in on the first pass is higher. Okay, next. So, third item, lights and sirens. Just wanted to give you some numbers. We've talked about lights and sirens. 6,500 ambulance crashes according to NHTSA. Average over the last 20 years, about 6,000 plus ambulance crashes. It was a high number. I didn't think there was that much. That included 33 fatalities every year. 91% of those was during light and siren transport. If you reduce light and siren transport, you reduce crashes. Salt Lake City reduced their lights and sirens by 50% over a period of time, reduced their ambulance crash rate by 78%. The other part of the equation is, well, why are we going fast? Well, the idea we go fast is we think it's going to make them better faster. But the majority of our patients, the majority, not all, there are some where that 5 minutes makes a difference, and you all have had them. But the majority of our patients don't benefit from the 5 or 8 minutes time saved. And so therefore is unnecessary for those people. You're getting added risk, no benefit, if you're transporting a patient that really you can manage them another 5 minutes, and it doesn't really matter whether they get into the emergency room now or 5 minutes later, 10 minutes later. So, since light and siren response to scene and transport to hospital will increase the chance of collision and injury and has limited benefit, we want to reserve it for those patients that are truly time critical And that's the question you ask yourself before you hit the lights and sirens. Most, oops, it did work that time. Most experts, as well as our local health department, not local, but state health department, feel that this approach can lead to about a 50% response to scene use of lights and sirens. So in other words, maybe half the time it would be appropriate if you use these strategies or think about it, but only 5% light and siren transport to the hospital from the scene. Of course, the reason for the difference is that once you're at the scene, it's your assessment. You know how that patient is, including how stable or unstable they are, based on your assessment, not based on an EMD dispatch. We've got great EMD dispatch that gives us good information, but we all know that sometimes the information they get isn't as helpful as it could be, and we arrive to find a patient that's a lot sicker than the dispatch was. So for that reason, kind of bear that in mind when you're going to the scene. You know, does this sound like a call where they might be, dispatch could be off and this patient could be a little sicker? In that case, then you can justify a light siren response. Once you get to the scene, you find out indeed, indeed this patient really is sick. They've got a poisoning that they need an antidote for, or they've got sepsis that maybe needs some early antibiotics and they're hypotensive. Or maybe it's an OB patient that's got a preemie breach that's crowning. You definitely want to get to the hospital quickly on that one, right? So there's some where you're going to light the fire like you always do, and you should. I'm not saying don't do it in those, but reserve it for those. We're tracking the numbers, RETAC-wide. Dr. McDougall keeps track of that stuff, and we're looking at it and having this kind of a discussion with all of our EMS agencies to try to get the numbers down. You guys are doing a really good job right now, I think, at it. We're doing pretty well, but shooting always to be better.
Grant, I'd like to make, if that's what we're going to try to shoot for, is 50% lights and sirens to scene. And in the past, we just almost had a policy, we go hot to scene because we don't know.
Mm-hmm.
What about this? And I don't know what we'd have to do to make it official, but if it's either one of the two nursing homes or the legacy, because that's kind of, you usually have a pretty good idea. The nursing staff can tell you. And I already would not look into those three places anyway, unless it's a critical call. Or if we have the PD on scene, if we've got their eyes and ears on scene, they can pretty much tell us if the person is in bad shape or not. So I would say a lot of times if PD's on scene and gives you a little bit of a early report, and it doesn't sound critical, no lights and sirens. Does that sound reasonable?
That sounds real reasonable to me. And those are the types of things. I'm not suggesting policy tonight.
Right,
I'm just
right.
suggesting broad stroke ideas. But that's a great, what Jim suggests makes perfect sense to me.
And I also wonder on those where it says most experts and CDPHE, are they talking the front range only? Or are they talking rural or urban EMS as
They're
well?
talking all. They're talking about countrywide, rural, urban, and frontier.
Okay. Because there's a lot of difference dispatching in the front range than it is here.
Yeah.
They do the whole different coding system, a lot different.
Yeah.
So that's the other thing we have to take into consideration there.
And we may find that 50% number is not realistic for us. But, so those are not numbers that we would penalize ourselves for. They're just broad guidelines that we're looking at to say, let's see if we can shoot for that and also learn from our experiences. Just like it's doing with the kids.
Dr. Hurley, can I butt in for a sec? Not that it really matters in my opinion.
Is he still recording?
Sorry.
Or is that one off? Is the audio
It's
off?
off for a moment.
Okay, get back to you momentarily.
Okay. He's recording, go ahead.
We can talk about
No, so the only thing I was gonna say is I already go to calls. I don't run a lot of sirens calls anyway, whether I'm working PD or ambulance. One, I take into consideration the time of day, the type of call, and we really how big is Mona Vista? You can drive across town without lights and sirens together in a 3-county manner. I mean, at nighttime, like for example, like yesterday, some of us might run. Like Jim said, we had a policy in place that said you run lights and sirens to all calls, but it's like, we really gotta run lights and sirens 2 blocks down the road for a guy who has a swollen hole next to his code them. That kind of stuff, you know what I'm saying? No, but seriously, it's common sense, I guess is what I'm getting at.
Okay.
Time of day, that kind of stuff, you know what I mean?
Yeah. Okay. All right, thank you. All right, guys, anything else on light sirens? We'll move on to the last topic. The Colorado MOST form. You're all probably familiar with it. It's the green form that you'll see handed to you when you pick up a patient from Veteran Center or one of the other nursing homes. Medical orders for scope of treatment. It's a standardized form. It's a Colorado-specific form. The Colorado End of Life Coalition is the organization that tries to standardize living wills, durable powers of attorney, proxies, MOST forms, advanced directives. So it is a standardized form, and in that sense, it's a legal document, but it's not a binding legal document. As you'll see when I show you the MOST form, just as a reminder, because I think you've seen them all before, it's just a form that's signed by the family or the proxy for the family, the durable power of attorney, and the doc. The MOST form is designed to guide treatment decisions, not so much about are they a code or a no code, because that part is easy. But we frequently forget, all of us have had to remind ourselves that no code does not mean no treat, right? So no code just means if they're dying dead at the time, arrest, unresponsive, pulseless, apneic, then that's when the no code orders kick in. But before that, and this is the majority of our patients, even if they are, hey, I don't want to be resuscitated under any means, they may want some form of care. The MOST form can be really helpful in guiding your treatment decisions for that, not just CPR, but for things like does the patient want antibiotics or IV fluids short of CPR? It is used by all of the nursing homes here in the Valley, and many, many, many of our elderly, chronically ill patients at home, their providers have them put them up on the refrigerator door. They're designed to be kept in a visible place, with a magnet type of a thing. The copy must be sent with you guys when you take a patient from the nursing home to the hospital, because it's also designed not just to give you ideas on care, but to give the receiving facility the same ideas on care. So it's a document that's handed to the receiving facility. But en route, this is your receiving facility, and so it's good that you can look at it and know what it means quickly, and we're going to show you that. Verbal report isn't really acceptable. If they say, patient's DNR, see ya, I'd say I'd like to have the MOST form. Insist on it when possible. It may not be possible if the need for treatment outweighs the need for the MOST form. Don't be a hardliner on it, but try to make reasoned decisions. You're chronically ill at home, frequently have it. Try to get it from them too. And the main thing is it can be really helpful for us in figuring out which treatments may be inappropriate or appropriate. Besides, they say, oh, we're no code, but is treatment X or Y en route an appropriate thing to do? And Drew's got a great case from 2 or 3 weeks ago where that came up. Here's the form. So the form's supposed to be green, but somehow it printed yellow. That's the form in its entirety, just to give you an idea of what it looks like, but I blew it up because I had a hunch that this would happen. And maybe we can read this. So the parts that we need to know, the first part A is, do they want CPR, yes or no? Okay, that one's pretty straightforward, never a problem. B is where it's helpful. I like to start at the bottom with this just because it makes more sense intuitively. The docs, the care providers at the hospital, basically the physician signs off on this. And so they find out if their patient and they feel that this patient only wants comfort-focused treatment, where you're just trying to maximize comfort, that's the main goal, or maybe a hospice patient or a cancer patient. This would be relieving pain and suffering with medication by any route, morphine and anxiolytics, oxygen, suctioning, manual treatment of airway obstruction, that type of a thing. That's comfort-focused treatment only. You wouldn't use anything above and beyond that, and because of that, it intuitively follows that that patient's probably not going to get transferred to the hospital unless the comfort measures can't be done at the facility, right? And that can happen once in a while. I think that there might be times where the nurses just say, hey, with the orders we have for the morphine or for the Ativan or whatever, it's just not cutting it, they're restless, they're choking, families change their minds, we're sending them in. So this doesn't mean that you shouldn't transfer them, but this means that the facility, the nursing home in this case, wouldn't be transferring them to the hospital if they're checked as comfort-focused treatment. Let's take another patient, and it may be a cancer patient, and they don't want a full code, but they want to treat reasonable medical conditions, but avoid burdensome measures. So in addition to comfort measures, which are always basic, that we do everything for, we're going to maybe say, hey, maybe a short course of IV antibiotics. Hey, you've got pneumonia, and it looks like we can clear this thing up in 2 or 3 days with IV antibiotics. Do you want to go to the hospital for it? The reality is that most patients, even do not code patients, say, oh yeah, if I'm going to live a little bit longer and it's easy and it's just go to the hospital, give me some IV antibiotics or give me a few respiratory treatments there, of course I want that. A UTI and I need IV antibiotics, something like that. Or maybe I'm having problems with severe nausea and I can't keep anything down and I need some IV fluids for a day. That's selective treatment. That means, hey, I'm DNR, I'm comfort care, but also for certain limited conditions, I want to go to the hospital for that. And then full treatment is full treatment. That means no holds bar up to and including CPR. Well, what happens is that this form is actually, and Arlen, you can correct me since you work at the nursing home, but the form, I'm told by a geriatrician colleague of mine, is actually filled out by the social worker in consultation with the patient and their family when the patient is admitted to the facility. And they do their best at filling it out. And frequently what they end up doing in their questioning is selecting comfort only, because that's kind of where they just tend to land. In the no-code patient. I mean, first the patient, it's easy for the patient to say, yeah, I'm done with code, I don't want a ventilator, I don't want intubated, I don't want that. But yeah, just give me comfort care. Well, it turns out then that if the doctor or the nursing care providers really talk to them in detail and say, hey, I know we're going to give you comfort care, but if you had, just imagine, if you had pneumonia and could get better in 2 or 3 days, would you want that? And if they say yes, then that needs to get changed from there to there, okay? If it's here, when you transfer them, then you do measures above and beyond comfort care. If they're being transferred because you can't control the pain or this or that, then you just do comfort care. So this is something that can help you as a care provider in the interim know a little bit more what the family wanted above and beyond code or no code. Drew had a real interesting case that raised that precise question not too long ago, and I'm going to have him just briefly discuss that with you guys for an example for this. You can just kind of give us a rough outline if you want, Drew.
So on May 26th of last month, we got paged out to the Veterans Center for an 84-year-old male who was having altered mental status, low blood pressure, and just really going downhill fast. So we get there.
And was this a no-code patient or?
This was a no-code patient, correct?
Okay.
But when we saw the most form, it was posted as, do you remember what it was?
He was no CPR and comfort focus.
Yeah.
So
no CPR, comfort focus.
there we go. Okay, comfort focus. That's
Yeah.
right.
That one there. So, okay, so we get him loaded up, we start heading off. His abdomen was really distended, and he was still lethargic, and he was, he had no times, one, to voice. I mean, you call his name and he'd look at you and that's about it. He'd make a gurgling sound and that was, as far as legitimate words or anything, it wasn't happening. So we had to go up to the monitor, blood pressure and everything. Noticed that his blood pressure was 80s over 40s, and it was going down. His heart rate was in the low 40s as well. Anywhere between 35 to 45. It would go up, it would come down. Dropped a line on him, gave him some fluids. So my question was, would this have been a good, we're trained to save people, so his pulse was low, he was fitting the criteria for atropine. And all the ALS people, would you have given it to him?
Blood loss is the problem.
Right. How did I know that?
Well, in Drew's defense, the abdomen really wasn't distended because that was his norm.
Yeah. Oh.
Yeah, it was his norm.
But Andrew didn't know that.
So he has altered mental status, low blood pressure, low pulse, and just really going downhill. So the protocol for atropine, what I have brought up on, is you give 0.5 of atropine and wait 5 to 10 minutes and then apply again. By the time I was already at the hospital, Dr. Eli Walker, he's like, we're not gonna give no more, and I'm like, okay, so.
So, yeah, this is a case then where, in this question, there are two issues. One is, do you give atropine to the symptomatic bradycardic person? The second question is, if indeed that is the correct application or interpretation of your protocol, should it be given to this symptomatic bradycardic person if indeed they're comfort care only? In other words, is atropine comfort medication would be the question.
Well, I would give him fluids and give him atropine.
The other thing that, and me and Dr. Hurley have talked, and so is the facility, when this patient was mine, and when he went down, his medication went down that morning, it went down significantly fast, like that fast from the day before. But his most form did say comfort-focused treatment. When the physician was called, he said ship it. Okay, so we're trying to clarify a lot of that because it was comfort-focused to begin with, and should we have transported him based off of that most form?
So
He thought he was treatable. He
Yeah.
thought he was.
I would say, yeah, I would, same thing. The doc says he's treatable, but they shipped him, they want us to do some, it says comfort focused. So my question would be to how far do I go with the atropine? Do I even go to pacing him? And I can't read the small print if I'm not supposed to pace. You're not doing CPR.
So those are all great questions, and the answer is that in an ideal world, I believe my interpretation would be is if a patient was comfort focused, the first question that could be asked, if indeed they truly were comfort focused, was, well, if they're comfort focused, why are they going to the hospital? Because bradycardia and hypotension are really not considered uncomfortable states. It's not as though you're going to make them feel frisky or better or out of pain by giving any kind of an intervention to help bradycardia. So that's the first question that comes up. And so I say in an ideal world, if this patient truly wanted only comfort measures, but in this case, the nursing staff appropriately called the physician, and the physician changed his mind, or her mind, or really thought that probably wasn't even really aware of what was checked on the most form, but just said, in their mind, this patient deserved some sort of intervention short of CPR, and they said, go ahead and transfer. So at that point, this patient then defaults into a selective treatment category because the physician said, send them, I want them treated, but don't code them. So at that point, I would think that treatment of symptomatic bradycardia, which he clearly had, even though we don't know the reason, could be intra-abdominal bleeding, it could be anything else. In this case, it wasn't medication, but it could just be a failing heart or high degree heart block, it could be a number of things, but our protocols say that, hey, if they're bradycardic and they're hypotensive and they're symptomatic from it, then consider medical treatment first before we do pacing. And so in that case, atropine would be perfectly acceptable.
So if it came down to it, and the doc was saying one thing, the power of attorney was saying another, who has the power?
Well, in this case, let me roll back to the previous deal, and you'll see the answer to that is, let's go back to the previous slide. You can't see here, but it's signed by the patient and or representative and by the doc. So in this case, I would just follow what the doc wanted them to do. And the reason that I say that in a perfect world is, I think it turns out in speaking with Arlen that a lot of these are not, the doctors are not as careful as they could be about really looking at the most form and checking the box that they really are applying. Arlen has told me that at the nursing home, most all of the patients are on the most form listed as comfort care, and virtually every one of those comfort care patients, if they got sick, wants to go to the hospital. And so the most forms are not
Was it not being
filled out correctly.
explained then correctly, or? Yeah.
Well, I think it's going to be an education of doctors, nurses,
Yeah.
and social
And
service
it
people.
comes down to a lot of the
Yeah.
education part, because they feel they're going into the nursing home and then they just want to be comfortable, you know? But with this gentleman, he was AAO times 3, or AAO times 4 up until 2 days prior.
Right.
Not even that, I mean,
Right.
prior.
Now see on here, it says, do not transfer to hospital for
Yep.
life-sustaining treatments.
Correct.
It also says transfer only if comfort needs cannot be met in current location.
Correct.
So is that like an oxymoron, or?
Yeah.
No, they're saying the same thing.
Meaning if we can't give them Roxanol, give them some anxiolytics, give them some Ativan on board, and we can't keep them comfortable, or I can't give them enough Roxanol to be comfortable, sublingually, then you can transfer to a hospital. Am
I
correct?
think in an ideal world, again, with everyone educated in an ideal fashion, the patient that does not want to be transferred for any reason but that wants to have comfort care, the physician will do the third box, comfort-focused treatment only, and provide orders already on the chart for morphine or Roxanol, PRN pain, Ativan or benzo of choice, PRN anxiety, and therefore acknowledging the fact that we're going to try to treat everything here. So, but even some hospice patients choose to go and get selective treatment.
And to be honest with you, there is a lot of our residents that will put comfort focus and then they get their UTI and they're hurting and they know that they can get better in a couple days, either by some PO antibiotics or IV antibiotics, and they'll automatically say, send me to the hospital. I can't tell you how many we've transported that. Just say, send me to the hospital. But their most form says comfort focus, plain as day. And they signed off on it, the POA signed off on it, they did, but they have a UTI and they hurt and they want to go get an antibiotic, and they go.
So, so hopefully this talk allowed you to understand the most form as being more complicated than it even appears, and the fallbacks that it entails, and just a little bit of the understanding so that you can navigate these things. Because I think all of us, I think it starts here though with you guys understanding what the most form means, that technically if it's C, it's kind of like, well, tell me again why we're transferring this patient? Is it just because you can't keep them comfortable? Because if they're truly a C, they don't really want to be transported.
Well, and Dr. Hurley, I'm going to tell you, we have a patient out there that is no CPR and full treatment.
Yeah. Yeah.
We do. We have no CPR, but we have full treatment to go full blown.
Right. Now that's the oxymoron, because
I know.
full treatment usually includes
So I have a
CPR.
question on that
Yeah.
if we are at home, not in a nursing home, but they have signed this one, and the POA shows up, and it says, nope, mom just told me yesterday she changed her mind and she wants full treatment. Do we go with what the POA? Okay.
Yes. I think a good idea is that in all conflicts, do what the patient or the person that's there at the time wants. because we human beings frequently change our minds. Yeah.
That actually happens in our nursing home quite frequently.
Yeah.
We'll call them and say, hey, your mom has pneumonia. She chose to stay in the nursing home. We'll make her comfortable. No CPR. Oh, no, send her to the hospital.
Yeah.
And the TOA is her signature. Send her to the hospital. Nothing.
So on my patient, he ended up having a perforated bowel.
Oh, wow. Dr. McDougall, anything to add?
No, I think the toughest side of this, like we kind of touched on, is the human side of this. That folks absolutely change their minds. That's probably the vast majority. Alternatively, one member of the family who, maybe out of touch or out of communication with the rest of the family, frequently have different ideas on what it is mom and dad, meant when they signed this. Avoid conflict, do what you can, if it's a patient you know closely, and kind of a nursing home, you kind of get some of that experience of you knew this, the patient wants it, they express it to you time and time again. And sometimes, you can kind of use the most formal, look, your mom said she would absolutely, under no circumstances, want CPR. Just told me that and assigned documentation to that effect. Is this really what you think your mom wants right now? Is this how she would want to spend her final moments? And so I find in that way the most can be kind of a tool. Hey, here's what, when your mom was thinking clearly and signed it herself. Here's what she was saying at the time.
Yeah.
Is this still true?
Yeah.
Good point.
So what if we have like the opposite? They call for something that's treatable, and the patient says, I don't want to go.
I know, that happens.
Yeah.
But the nurse says, you have to go. Our doc said you have to go.
Yeah.
I don't want to go. What do you do? Because we have that all the time. Patient's like, I don't want to go. I don't want to go.
Well, in that case, that most form is designed to protect the patient's wishes. If the physician signed off and the patient signed off that I don't want to go under any circumstances, and they're still lucid and they say that still holds true, don't take me, then you shouldn't take them.
Well,
But we
also,
listen to the patient, not
you,
the
I
nurse.
mean, technically, you could. And I mean, if the patient wants to go that far because we're taking them, they don't want to go, and the nurse is saying, yes, you have to go.
Well, and that's, I would listen to the patient, not the
Okay.
nurse. Listen to the patient, not the nurse.
Be careful when you do that, though, or they haven't had a head injury.
Oh, no, this
This
one
one was a fall.
is pretty with it.
Okay.
All right, guys, well, thank you for bearing with the glitches and such. Hopefully it was helpful, and we'll get it posted up there and maybe try this a few more times to make it go a little bit more smoothly. That's it.